Atherosclerosis is a lifelong disease. It can start in utero, can start before you're born, but you typically don't present to a doctor with symptoms until you're in your 40s, 50s, or 60s. And people can live their entire life, have these plaques, and not know that they're there until one of two things happens. The plaque builds up to where it's occluding the artery 70%. The artery is occluded 70%. People tend to have symptoms while they're exercising because they can't get enough oxygen and nutrients past the obstruction, or they have a plaque that ruptures. The plaque ruptures is like a pimple on the wall of the artery popping. All the cellular debris spills out into the bloodstream, the blood clots, and the person's having a heart attack. If they have erectile dysfunction as a man, that's the canary in the coal mine that the blood vessels, the sectional organs aren't working well. You likely have vascular disease in your coronary arteries. You need to go looking. The thing that you're treating is that it's the plaque that is more soft or more immature, the plaque that hasn't fully gotten a thick cap over it or calcified. You want those softer plaques to what's known as delipidate. You want the cholesterol to be basically pulled out of that plaque. So you're thinking of like shrinking a balloon down. So if you can delipidate a plaque, then the plaques can start to regress or shrink.
Dr. Twyman, as a cardiologist, the first thing I want to get into with you is arterial plaque. And let's start with the risk factors. If we go to the root here, what is causing it?
There's over 300 to 400 different risk factors that drive vascular disease, but it always starts with endothelial dysfunction. So the endothelium is the inner lining of your arteries. If you took out your endothelium from your arteries, which there's nearly 60,000 miles of arteries, you'd have the surface area of 6 tennis courts. So the endothelium is one of your largest organs that you had no idea that you probably had. But if something damages that lining, that's setting you up to develop plaque. And this can start in your teens or 20s. So you got to go looking well before the person shows up at the hospital with chest pain and shortness of breath.
All right, well, let's go back even further then. The endothelium, this is where the problem starts. What are the biggest things causing damage there?
I mean, the top 5 are still the top 5. It's high blood pressure, smoking, high cholesterol, which we'll talk more about, obesity, and I think that's it. For obesity, smoking, high blood pressure, lipids, and diabetes. Those are the big top 5.
All right, well, let's get into mechanism. Obviously, you've named 5, and the mechanism is potentially different depending on which one we're talking about. But let's start with the metabolism piece, metabolic health. You mentioned diabetes, different words for a very similar thing. This is a big one, and one a lot of people don't realize. When they're having too many sugars and carbohydrates, insulin's going up in response, and that can cause damage to the endothelium. So let's start there.
So it actually damages the thing that protects the endothelium. It's damaging the glycocalyx. The glycocalyx is a carbohydrate-rich, basically gel coat that lines the arteries. That coating gets damaged by high insulin and high glucose.
Okay. So why, when that gets damaged, do certain areas get impacted first then?
Because if the glycocalyx is impaired, the underlying endothelium has difficulty producing nitric oxide in sufficient levels. Nitric oxide is a vasodilator, so it keeps the arteries open. Nitric oxide helps relax the smooth muscle in the arteries. Nitric oxide helps prevent lipoproteins, white blood cells, and platelets from sticking to the artery in the first place. And it's the lipoproteins getting retained and the inflammatory response that really kicks off the plaque cascade.
Okay, to make sure I have this right, we got our glycocalyx, it's damaged. Then the nitric oxide production is interfered with. And then the cascade happens on top of that?
Correct.
Okay, what I was getting at there, why certain areas and not others? If we take it all the way back to the glycocalyx and say blood glucose is high, insulin's high, why specific areas are building up plaque versus others?
Again, you have nearly 60,000 miles of blood vessels, so you have to go looking, but generally plaque is not uniform. It tends to form in places of high shear stress, so where there's bifurcation points of arteries. So if an artery kind of has side branches, wherever the blood flow goes down those side branches, there's eddy flows of flow. That turbulent flow damages the glycocalyx, and then that's why plaque tends to build up in those branch points.
Okay, let's zoom in on this nitric oxide piece. Let's talk about the anatomy of a plaque building when that's disrupted.
So when a lipoprotein gets retained in the underlying intima, so the intima is the layer underneath the endothelium, white blood cells come in to investigate why lipoproteins are being retained there. The lipoproteins are, for people watching, I always use like a tennis ball analogy. They're cargo ships. The lipoproteins have the cholesterol, the triglycerides, the fat-soluble vitamins, the phospholipids, which all build cells. But if this makes a detour and gets stuck in the arteries, that causes an inflammatory response. Basically, the body thinks bacteria is invading. The white blood cells start gobbling this up, and the cholesterol is now, causing this crystallization process in the intima. The intimal layer will start to swell. Eventually, the processes will develop plaque. The body will then try to put smooth muscle over the plaque to seal it into the artery, like a scar. It may also eventually calcify the plaque, literally turning it into bone. And people can live their entire life, have these plaques, and not know that they're there until one of two things happens. The plaque builds up to where it's occluding the artery 70%. The artery is occluded 70%. People tend to have symptoms while they're exercising because they can't get enough oxygen and nutrients past the obstruction. Or they have a plaque that ruptures. The plaque ruptures is like a pimple on the wall of the artery popping. All the cellular debris spills out into the bloodstream, the blood clots, and the person's having a heart attack.
Okay, so it sounds like there's two different scenarios here. Slowly occluding over time, or a rupture, and then things happening more abruptly.
Atherosclerosis is a lifelong disease that can start in utero, can start before you're born. But you typically don't present to a doctor with symptoms until you're in your 40s, 50s, or 60s. So it's never too late to start treating, but it's also never too early to start looking. If you don't look, you don't find. Atherosclerosis is something that if you intervene early on, you don't go on to have the cardiac events. You don't require stents and bypass surgery. So in the first scenario, if the plaque is building up slowly enough, you eventually may get an artery occluded, 70, 80%, and you start presenting with exercise-induced symptoms, chest pain, shortness of breath, exercise intolerance. You go to your doctor and say, I'm not feeling well with exercise, and then they put you on a treadmill and they run you. And then you, quote, pass the stress test or fail the stress test. But that's kind of late to the game. If you fail a stress test, you're often going to go to the cath lab and they're going to say, oh, you probably need some stents. They'll put a stent in. The stent will relieve the symptoms. You'll feel better with exercise, but the stent does nothing to reduce your risk of having a heart attack because it didn't treat why you got the blockage in the first place. The stent is a Band-Aid, and you need to get to the root cause.
As a cardiologist working with patients, looking at what's happening inside the body, do we all have plaque by the time we're adults?
Not all, but the greatest majority of people, if you go looking with the right tools, you'll eventually find it. Particularly if you use some of the newer testing that's using AI image guidance, you usually find it. In almost every man over 40, I've always found plaque in them.
And what's best case scenario? Somebody that has this slow occlusion, they come to see you, they get on a treadmill, they find out there's a problem there. They say, okay, I'm ready to take this seriously now. Tell me what to do. What's the best they can hope for at that point?
Well, the thing that you're trying to do is first find it, analyze why they're developing that plaque, and then stop it. Plaque is, something that, if you're looking for it, you're going to find it. But not everybody with plaque goes on to have a heart attack, stroke, or suddenly die. Those are the people you're trying to figure out. What is the vulnerable plaque versus the more stable plaque? And the vulnerable plaques tend to have a lot more inflammation and oxidative stress, which you can test on blood testing markers. But in my office, I do a lot of functional testing to look at how healthy is the underlying endothelium, and by default, the glycocalyx. So testing that looks at nitric oxide availability, testing that looks at central blood pressures, test that looks at pulse wave velocity, how stiff are your arteries. If you have all these markers that the arteries are stiff and you have low nitric oxide, then you're in the process of still likely continuing to lay down plaque. This is not an old problem. So you want to figure out, do you still have ongoing fires in the arteries? And this testing can easily kind of help determine those people.
Okay. So obviously, if there is fire in the arteries, we can at least stop it by making the changes we're going to get into. But is there such a thing as reversal? Somebody middle-aged coming to see you, they're clogged up. Again, they want to take this seriously and do what you're telling them. Can they actually reverse that accumulation that's happened there?
To a degree, yes. The first goal is find the plaque, stabilize it. If you can prevent a cardiac event, that's winning the game. If you get all the variables right, then plaque has the potential to regress. Will it go all the way back down to completely normal? May not, particularly if the plaque is already calcified. It's not even the goal to get the calcium to regress. The calcium is a scar, and you don't want to disrupt the scar. The thing that you're treating is that it's the plaque that is more soft or more kind of immature, the plaque that hasn't fully gotten a thick cap over it or calcified. You want those softer plaques to what's known as delipidate. You want the cholesterol to be basically pulled out of that plaque. So you're thinking like shrinking a balloon down. So if you can delipidate a plaque, then the plaques can start to regress or shrink.
All right, let's talk about the specifics. Somebody wanting to go through that process and delipidate. What's the first step?
One, I usually tell people like focus on optimizing your glycocalyx and nitric oxide. Because if you do that, that's like putting back up a force field. If you keep your force field up high, you potentially will stop doing damage to the arteries. The arteries aren't going to delipidate and shrink plaques if you continue to do damage to them. If you have endothelial dysfunction, you're still likely laying down plaque. So fix that process. How to do that? It's going to depend, but some general variables are exercise is extremely important. As you flow blood across your arteries, the arteries are going to upregulate the ability to release nitric oxide. As you eat foods that are rich in nitrates, which are mostly the green leafy vegetables like spinach, kale, arugula, or beets, the nitrates can get broken down into nitric oxide if you have a healthy oral microbiome. And the third lifestyle thing that can improve nitric oxide release is UVA sun exposure. So when you're outside and your skin's feeling warm, the UVA spectrum of light is causing nitric oxide to be liberated from your skin. So do the three things first. Blood tests can point to things that might break your nitric oxide pathways like elevated homocysteine, elevated uric acid, high insulin and glucose, high asymmetric dimethylarginine. If you find those things, start pulling on those levers and getting those back to normal. So if you get nitric oxide improved, you support the glycocalyx with potentially some supplementation, then you start tackling bucket number two. And bucket number two is the oxidative stress and inflammation. So looking at markers like high sensitivity CRP, LP, PLA2 activity, myeloperoxidase, oxidized LDL. If you start seeing a lot of oxidative stress and inflammation, figure out what's driving that process and shut that down. And then the third bucket is do something to affect their lipoproteins. If they have plaque, there's cholesterol in that plaque. Now, cholesterol is not bad for you. You need cholesterol. Without cholesterol, you're not going to be alive. You need your cholesterol to make your sex hormones, your bile acids, your cell membranes. But if you have too many lipoproteins, think of it as too many cars on the highway, there's more likely to be a traffic jam in your arteries. So use whatever tool to get their numbers to goal. I generally shoot for an ApoB around 70 or less for people who have known plaque in their arteries. So often they're going to be using medications like statins or ezetimibe or one of the PCSK9 inhibitor injections or the new medicine Nexletol. There's a time and place for lifestyle interventions and supplements, but if you have a lot of plaque in the arteries, you're going to want to use the big guns and start putting the fires out sooner than later.
And how often, when you pull out the big guns of the patient, if they're committed to this diet and lifestyle, can they eventually get off those?
I mean, the short answer is, why would you want to treat something and then stop? Because if you don't fix the root cause, you stop some therapies, you're just going to go right back to your baseline, unless you made other significant changes.
Well, that's what I said. If you make the changes, you're hearing what's going on here today, and you're going to drastically change your lifestyle and diet.
Correct. So you may be, somebody who has insulin resistance. You can reverse insulin resistance. That's definitely possible. But that does not mean that you can, automatically come off your statin or your antiplatelet agents or things that are supporting nitric oxide, because those are different variables that are affecting the arteries. You might not need to take metformin or pioglitazone or an SGLT2 inhibitor or a GLP-1 anymore for your, insulin resistance diabetes, but you do need to continue to focus on keep nitric oxide high, inflammation low, lipoproteins controlled through whatever combination. And if you had significant improvements in your lifestyle, then yes, maybe you can start de-escalating some of the therapies, but it's rare that you would come off everything.
You gave that analogy there, too many vehicles on the road when it comes to lipoproteins. When looking at lipoproteins, how much of it is the actual number of them versus the quality, specifically when it comes to LDL?
Typically, you're wanting to know the number of particles. It's more important the number than necessarily the size. But if people can have a lot of small LDL particles, it's generally either genetic or it's due to insulin resistance. And so if they got insulin resistance, then go start tackling that. Particles predict risk. So, it's a gradient essentially. You have way more particles in your lumen. If you have a damaged endothelial lining, there's always a risk that those lipoproteins are going to get retained there. So You would dial back how many cars on the highway, so there's less likely a traffic jam. It's a numbers game, honestly.
Depending on who I talk to, it seems like LDL as a whole is potentially the bad guy. And certain people in our space are saying it's just a small, dense LDL. In your case, you're saying it's not as black and white as that.
It's not as black and white as that. And, there's no such thing as bad cholesterol. Again, everybody needs cholesterol, but you don't need lipoproteins dropping that payload of cholesterol off into your arterial walls. And the things that drop off lipoproteins in the arterial walls are the ApoB containing particles. The lion's share of them are going to be LDL particles, but some people have VLDL particles that are high. That's, again, usually insulin resistance. And 20% of the population has lipoprotein A or Lp(a). That also has ApoB proteins on the outside of the lipoprotein. And that's the issue, is that if you have high Lpa, there's no drugs that effectively lower it. You're at double approximately risk of developing plaque in your arteries compared to somebody who doesn't have Lpa. So it's the lipoproteins carrying ApoB that are atherogenic. Now, if there's a lot of oxidative stress and they're getting modified, those are the ones that tend to get retained more vivid or more avidly in the arteries. But even, quote, big fluffy type LDLAs, can still get retained in the arteries. So it's not that everybody with high cholesterol ends up with plaque in the arteries, but if you have plaque in the arteries, it got there somehow and you're going to want to do something about it. The fact still holds that half the time people have heart attacks, they have normal cholesterol. So cholesterol is not the only, thing that you need to focus on. But also half the time people have heart attacks, they had no symptoms before they had a heart attack. They had a very mild plaque that ruptures. So you're trying to prevent events, and lowering lipids lowers events.
Let's come back to Lp(a). This seems to be getting a lot of momentum in our world. Talk more about how somebody tests for that and what it means. And traditionally, in conventional cardiology, a lot of doctors are saying it's strictly genetic. Other people are saying that you can modify it slightly depending on diet and lifestyle. Expand on how you feel about that.
So lipoprotein A is under genetic influence. Everybody has it, but 20% of the population has elevated serum levels of lipoprotein A. Lpa is very similar to LDL, but it has an extra protein on it, apolipoprotein A. That protein allows it basically to stick to the artery a little bit more aggressively. It also is more likely to cause the blood to coagulate or clot. It's a protein produced in the liver. If somebody has significant inflammation, that inflammation can worsen Lpa levels. Lpa is a scavenger. So if you have a lot of inflammation, Lpa is busy. If you don't have a lot of inflammation, Lpa may be just setting at its normal set point for your genetic predisposition. So there are not great lifestyle interventions that have much effect on Lpa. The only thing that has any real effect at lowering Lpa is apheresis. And not very many people are signing up to go into the hospital, get their blood taken out, spun down, and re-injected back in them, because it's a short-term fix, and you got to keep doing it every couple of weeks. So more popular in Europe, not necessarily so popular in the United States. The only drugs that really have effect in the United States, and it's not significant, is the PCSK9 inhibitors. Those can potentially lower Lpa 20, 30%, but that's not yet known if that clinically is significant. So Lpa is a risk factor for vascular disease. People who have strong family histories of vascular disease, so grandpa, dad, all your uncles had heart attacks in the 40s and 50s, you probably suspect people have Lpa in that family until proven otherwise. The way you test for it, simple blood test. Blood test that costs less than $20. You only need that test one time in your life to know if you have high serum levels at that point. Now, if you have a very strong suspicion, there is genetic testing you can do that can tell you how many Lpa genes you have, but the serum test is usually good enough for the majority of people.
Let's come back to very high level here. Somebody coming to see you hasn't given a lot of thought to what we've been talking about here. They're middle-aged. They likely have some plaque developing, but they're ready to make changes. What testing do you do initially when you're working with somebody new? And then we can work into preventative lifestyle at that point.
So for patients that work with us at our practice, we start screening them head to toe, starting with oral salivary nitric oxide pathways. So test strip can tell you, can you make nitric oxide through your oral microbiome? We look at an ultrasound of the carotid arteries, which are the arteries that take the blood in your neck up to your brain. They're windows into your vascular system, and you can use an ultrasound probe to access them, so no radiation. You have access to looking at the intimal thickness on that scan. The thicker the intima, the more inflammation in the artery, the more likely the person's developing plaque. You will also see if they have plaque in their carotid arteries. For the coronary arteries, depending on age, depending on if they've had previous testing that looked at their arteries. So if they've already had stents or bypass, they're high risk. That's not the people who are generally, screening. There's people who are more, hey, they got family history, they have, quote, high cholesterol. And those individuals, if they've not previously had the test and they're over the age of 35, generally we'll start with the CT coronary calcium score test, or if they have enough risk factors and family history, maybe a CT angiogram where we're actually looking at the flow of the blood in the coronary arteries. But that requires a CT scan and radiation. We also will look at blood pressure, of course, but we're also looking at central aortic blood pressure. That's a blood pressure that comes out of your heart. That's a blood pressure that your heart, brain, and kidney sense. I was an invasive cardiologist. We would measure that with a catheter in your arteries in your wrist or your leg arteries. But since people don't want us putting needles in them, we have a non-invasive device that can look at that. It's called the Accor. There's now a home device that can estimate as well called the Connect QT. We look at pulse wave velocity. So we put a probe on the finger, gives us your heart rate, but also gives us how stiff your arteries are. So blood should go into the arteries, expand them, snap them back, like an accordion. The quicker it snaps back, the healthier the artery. We have another device that looks directly at how efficient do the endothelial cells release nitric oxide. That test is called the EndoPAT, 15-minute non-invasive test that we basically pump up a blood pressure cuff higher than your blood pressure. So we cut the flow to your arm for 5 minutes. And after we open up the blood pressure cuff, the blood rushes back down into the arm. And that reactive hyperemia causes the body to release nitric oxide. So reactive hyperemia is just the rush of blood coming back into your arm. It stimulates the glycocalyx. The glycocalyx senses the flow. The underlying endothelium releases nitric oxide and the arteries relax. Your arteries should generally at least double in size, but optimally they should triple in size. If they don't, you have endothelial dysfunction and you're more prone to developing plaque in your arteries. We look at the abdominal aorta. If you have a dilated abdominal aorta, you have an aneurysm. That's associated with atherosclerosis, but often found in people who are long-term smokers or have uncontrolled blood pressure issues. We also look at ankle brachial index. So we check the blood pressure in your arm, but then we look at what is the blood pressure in your legs. And you divide it, you get a ratio. Your ankle brachial index should be greater than 1. If it's less than 0.9, there's suspicion you're going to have blockages in your leg arteries. If you've got blockage in your leg arteries, you probably have it elsewhere. So that's what we do for biophysical. And then we do a whole host of genetic and biochemical analysis as well.
Let's talk about that while we're in here.
Now, we typically use either Boston Heart Diagnostic or Cleveland Heart Labs. Both are excellent lab companies and have all the advanced, vascular markers that we tend to look at. So as I said earlier, I usually kind of break it up into 3 buckets. It's what are things that are affecting the nitric oxide pathways, how much oxidative stress and inflammation you have, and then looking at the lipoproteins directly. What is your number of LDL particles, how many ApoB particles you got, do you have high LPA? All those things are seen on those panels.
So you've mentioned nitric oxide a number of times, obviously highlighting the importance there when it comes to heart disease and prevention. You mentioned the leafy greens and that being part of producing it. You also mentioned the oral microbiome. And I know a piece of that is not using at least conventional mouthwash and killing the microbiome. But let's take it from both ends on nitric oxide, including the piece I just shared. Get into more specifics on what we're doing, killing off things in the oral microbiome and other things we're doing to hinder it. And then we'll move into things we can do to up it.
So things that can affect the nitric oxide pathways, are physical activity. You don't exercise or force any blood across your glycocalyx. So the underlying endothelium is not stimulated to release nitric oxide. But the oral systemic pathway, that requires a healthy oral microbiome. You need nitrate-reducing bacteria. There are testing that now are starting to come online that you can test to see, do you have these type of bacteria? But if you don't have nitrate-reducing bacteria, you can eat all the green leafy vegetables in the world you want. You're not going to be able to make nitric oxide through that pathway. But where it mostly happens is that people are using antiseptic mouthwashes and they kill all the good bacteria in addition to all the odor containing bacteria. You don't want to be doing this. The other thing that happens is, people are using things with fluoride in it. Fluoride tends to disrupt or change the oral microbiome. So you use fluoride-free products. Definitely don't have drinking water that has fluoride in it. And stomach acid. You need stomach acid to break down proteins. You need stomach acid to make certain enzymes. If you're using proton pump inhibitors or tons of antacids and have low stomach acid, you're not going to make nitric oxide through that pathway. So sometimes it's about removing the damaging things, not necessarily adding things to the regimen.
Okay. A couple highlights there I want to dive deeper into. The proton pump inhibitor, somebody that's been on those affecting stomach acid, if they're going to wean off those with a doctor in a healthy way, does the stomach acid tend to come back naturally?
It may need some support. You might be able to, get by using some apple cider vinegar, and you might have to definitely go through a kind of wean off protocol. You're not going to be able to stop cold turkey. So you have to work with somebody who's done this before.
Okay, and then same thing for the oral microbiome. Somebody that's been using mouthwash killed that bacteria that we need to produce NO. Is there a way to reinoculate that through a probiotic, or is it just about leaving it alone and letting it come back naturally?
There are companies that are working on different like probiotic gums that can help stimulate the right type of bacteria. Also, there's nitric oxide technology products that are oral dissolving lozenges that release nitric oxide, and just having nitric oxide being released in that pattern can help with basically growing the good bacteria. So just having more sufficient nitric oxide tends to bring the other ones back online.
Is that Dr. Nathan Bryan's product?
Yes, his products do that.
Any other companies?
Calroy makes a lot of the probiotic gums.
Okay, let's talk about other than the leafy greens, other supplements. You mentioned exercise as well, producing NO. But dietary-wise, supplement-wise, things we can take other than Dr. Bryan's products to enhance that.
I mean, there's companies that sell concentrated beetroot. You got to make sure you're working with a reputable company. But there's a company called Beat It. Their products have the 300 milligrams of nitrates in them. A lot of Olympic athletes use that as their kind of pre-workout, because if you have enough nitric oxide, it helps vasodilate the arteries and you get more blood flow to the muscles. So Beat It, or the older product, Super Beads, the powder, not the chews, can be beneficial.
Exercise has come up a couple times, once directly to NO production. Somebody right now who has been metabolically unhealthy, they're overweight, they've determined they have plaque, and they're nervous about exercising because of that. But part of the remedy to what they're facing right now is the fact they haven't been exercising and treating their body right. How do you work with somebody in that situation?
So somebody's been inactive for an extended period of time and is not been pushing it, so they don't know if they have exercise-induced symptoms. They should see their doctor and talk to them about what kind of exercise limitations they may be facing. Some patients, depending on risk factors and other things, they may require getting a stress test before going on a supervised exercise program. So you definitely want to make sure that is it safe enough for you to exercise. But if it is, exercise is one of the best drugs at helping release nitric oxide and keeping the blood pressure flowing appropriately.
And somebody like you who's tuned into this, coming back to the leafy green piece, somebody that has the proper bacteria in their mouth to make that conversion and produce NO, is there a certain dosage or frequency with certain greens you like to get to make sure you're keeping that bumped up?
I mean, you need a dose generally of at least 300 milligrams of nitrates for that oral pathway to really work well. And, they make the little test strips. They're a good starting point, but they're not always 100% effective, because if you have an oral infection, they're going to be falsely looking good. And that person probably does not have healthy nitric oxide levels. So you have to look at the whole picture. Like, does the person have normal pulse wave velocity? Do they have normal blood pressure? Okay, good. You're not as worried about what's going on in the oral microbiome at that point. But that's the challenge, is that, trying to get it through dietary means alone sometimes is challenging for people. They're not eating these things on a routine basis. Or if they are and they're trying to be more health conscious, they're eating organic foods. Organic foods are good for certain reasons, but the soil is nitrogen poor because they're not adding fertilizer to the soil. So the nitrogen rich soil has less nitrates available. So it completely depends on where your food's grown. So this is why it's very challenging to say like, oh, you have to eat 5 pieces of celery a day to get your nitrates. That might be true if you're in Texas, but if you're in New York, you might need 50 sticks of celery. It depends on the soil conditions.
Okay, so I want to go over high level what the different inputs are for NO again. Exercise, the leafy greens, you mentioned beet powder. We talked about the lozenges. Any other big ones I'm missing?
The big one is it's the UVA sun exposure. It's sunlight. Sunlight is the free one. And that's one people usually don't utilize effectively. So midday sun on your skin liberates nitric oxide.
For somebody that's on an animal-based diet, carnivore diet, keto diet, they're not getting very many or any leafy greens. I'm assuming by what you just shared, they can make up for that through sunshine, exercise, other means. How do you feel about those people when it comes to NO versus somebody including the leafies?
I see these patients all the time. And they're often low in their oral nitric oxide pathways. It's expected because they're not putting a lot of, precursors in. But it always depends on what's going on with the arteries. If they got stiff arteries, they got high blood pressure, you're probably going to use some type of nitric oxide technology to help them.
So you would say more times than not, somebody on that diet, carnivore or down on the continuum in that realm, is going to need to bump up NO?
Not necessarily. It's that they're going to be low in their oral pathways. But are they doing the other things? Are they getting their sun exposure? Are they exercising? Do they not have inflammation for other reasons? Yes, they might be, quote, metabolically healthy, but they could have high, homocysteine through a methylation process. That has nothing to do with your diet. So if you don't fix their high homocysteine, they're probably going to have low nitric oxide through having high asymmetric dimethylarginine. So it's individualized to the person who's sitting in front of you.
All right. Given what you just said there about the individual nature, I agree with that. What kind of diet, in a general sense, do you recommend for patients? And what kind of diet are you consuming as prevention for the heart?
I think people sometimes get too far into the weeds on, saying that there has to be some kind of perfect diet. There's just not. It really comes down to how efficient your mitochondria are. And that's why behind me on the wall, there's a giant mitochondria, because that's what I'm talking about with my patients more often than not. Your mitochondria are your engines. You get your mitochondria only from your mother. So that's why my, intake history with patients, I want to know how healthy their mom is, how healthy the grandma is, because you inherit your mitochondria through that lineage. Bear with me because it's going to be important with why I talk about this prior to talking about nutrition. Your mitochondria are your engines. Those are the engines that are going to metabolize the electrons that are coming from your carbohydrates and your fats. So if you have healthy mitochondria, you can eat almost anything and your mitochondria are going to handle it. If you have very poor functioning mitochondria, you're going to need a lot cleaner because your body is not going to be able to tolerate the oxidative stress from eating processed foods that are highly, enriched with things that your body doesn't know what to do with. So the mitochondria don't eat carbs or fats. They take electrons, run them through the electron transport chain, and your body makes ATP, water, carbon dioxide, and heat. That's what the body is making. It's the metabolic water that you're utilizing. So it's quantum physics. That water is what's storing energy. The ATP just helps fold proteins. So that's why I ask about that first, because if you have poor mitochondria, you're going to need to do more. But that being said, I usually start with people should be focusing on what kind of maternal haplotype they have if they know that information, because that gives them an idea. If they're people who are L haplotypes and they're equatorial, that means they could eat a high carbohydrate diet year round and probably be fine. But if they have a Northern European haplotype, then in the wintertime, probably a keto carnivore diet is probably more situated for them. But if you take somebody who has a Northern haplotype and put them on the equator and say, keep eating keto, it makes no sense. That's not how they were evolutionally designed. So you need to know where your mitochondria originally came from, but then you also need to know where the person's living in the world at this time. Your latitude matters. People should ideally be eating a seasonally appropriate diet. Assume it was 200 years ago. What kind of food did you have access to? What's growing in your local environment? Because that food is quantized to the light environment that you're in. So think of food as basically stored up sunlight. If you're eating plant-based materials, photosynthesis grew that plant, you eat that plant material and you break it back down into electrons and basically reverse sun exposure into your mitochondria. Now, if you're eating an animal, you're doing the same process. But where I'm at in St. Louis, there's 4 seasons. So if people are going to go for optimal nutrition, the wintertime, the ground's frozen here. There's no fruit or vegetables growing in this region. So you would have been animal-based by definition 200 years ago, unless you had the capacity to salt something, can something. So you would have had a seasonally appropriate diet. And then when the vegetables came out in the spring and summer, and the fruits later in summer, you would have eaten those things. We were designed to be omnivores if you had the opportunity to do that. So I tell people, you had to focus on the mitochondria first. And then if people want the basics, one, food is also energy, but it's information. It's information about time of day. So people should be eating during daylight hours. The body craves consistency and trying to figure out is it daytime or nighttime. So if you stop eating 3 to 4 hours before bed, the liver and gut clocks shut off and the body can metabolize that food. Next, I talk about protein. It's extremely important for your metabolism, but you need protein for your skeletal muscle, your bones, your immune system. Most people, maybe not in your community, underdose, but typically you need at least 90 grams of protein a day just to maintain what you got. And if you're trying to go for optimal or you're trying to gain muscle mass, you really need to go for a gram of protein per pound of ideal body weight. So if you're a 160-pound man, you probably need at least 160 grams of protein a day, broken down in 30 to 40 gram portions. And then seafood. Seafood's extremely important for brain and retinal health, the DHA component. Without DHA, you're going to have a bad time with your retina and brain long term. So I usually ask questions about how much seafood the person's eating in a week, how much protein on a daily basis, and then what time of day are they eating their meals. I start there. Then everything else is based off of what their goals are and what the genetics ultimately show me. So I know it's a long answer because it's individualized again to the person in front of me. There's no specific diet that everybody should be following.
No, that all makes a lot of sense to me. I love the quantum stuff. Given your situation, I think it'd be a good exercise to go through the year in a general sense and talk about how your diet changes. You mentioned you have 4 seasons, you're in St. Louis. Just give us a brief overview in each of the seasons, the main part of your diet and how that changes throughout the year.
I'm telling people what is optimal, but what I do doesn't necessarily matter for what they do because I don't always follow the rules. Nobody follows all the rules. I usually tell people the sicker you are, the closer you have to follow what Mother Nature or evolution designed for you. The better your redox potential and your mitochondria are, the further away you have to be from perfect. Quick sidebar is that there's famous stories that Usain Bolt during the '08 Olympics did not like the food in the Olympic Village, and he would sneak out and go to McDonald's and get chicken nuggets. And he still ran faster than anybody in the world that ever run at that time because his mitochondria were so optimized to take any foodstuffs and strip it down into electrons and run it through his Ferrari engines. So food is important, but there's a lot more things that people have to focus on. So I focus more on optimizing sleep and my environments before I worry too much about food. Now, for myself, I'm mostly paleo template, probably for 12 years now. Do I strive off it a little bit, but most of the time it's high protein in the morning, eggs, some type of sausage often, lunch, sometimes seafood, sometimes beef, pork, chicken. I eat all sources of protein. At dinner, it's usually another one of those type of options. Eat some greens, not a ton, and I eat very little fruit. If I eat fruit, generally it's going to be berries for the most part, just because I just don't love a lot of fruit.
Okay, before you go into your diet, it sounded like you said the circadian piece is more important for you. Do I have that right?
For me, because most people don't have that even remotely dialed in. So I think people have to lock in their light environments and their sleep first before really fine-tuning their nutrition plans.
All right, well, let's talk about the biggest mistakes people are making in those areas.
One, they're probably not going outside and seeing the sunrise. You need that light information to hit your retinas, activate the melanopsin receptors, send signals to your supracosmic nucleus. And that's basically the master clock in your brain that tells the rest of the organs, what to do, what time of day it is. And then for sure, people are often abusing technology at the wrong times of day. And abuse is a, somewhat light term. It is abuse to your, mitochondria. So the thing we're doing right now, talking on blue lit screens, It's amazing. I talk to people from all over the country and all over the world, but this can have a health toll. So the light coming off these screens, it's set at the exact same color as solar noon is in your environment. So, okay, it's daytime right now. Probably not the biggest deal, but I'm still going to wear my blue blockers when I'm on this because that's more blue light than I want to get in my eyes. I don't want my clocks to think it's the wrong time of day. But the key time is sunset. The sun sets, it should be dark where you're at. Maybe a fire, but nobody's necessarily going to live that way anymore. They're turning on all their LEDs and compact fluorescents, and maybe if they're biohacker, they got their red lights on and stuff. But darkness needs to happen in your environment to get optimal sleep. So if you get your light environments right, you generally get your sleep right. And when you get your sleep right, almost everything else gets easier. The hormones get balanced better. Your neurotransmitters get, better turned on at the right times of day. So I'm very much a stickler to my own personal light hygiene habits and try to, live by example. My office here is, all naturally lit. I have very few things that plug into the AC power grid unless that absolutely has to.
Okay, zooming in on sleep, other than getting the light right during the day and at night, what other pieces do you make sure you're doing in that realm?
I mean, the two biggest zeitgebers or time givers to your body is the light that enters your eyes and the timing the nutrients come into your GI system. So I said earlier, but ideally, you don't want to eat 3 to 4 hours before you go to bed. That allows the liver and gut clocks to shut off for the night to start processing the foods that you ate earlier in the day. So if you do those two things, most people's sleep quality tends to improve.
What about eating first thing in the morning? There's kind of a mixed opinion in our world about intermittent fasting versus getting that bolus of food, specifically making sure we're getting enough protein to trigger the body.
Again, it's going to depend on the individual that's sitting in front of you. But if somebody is overweight, obese, then they really do need to be very mindful that they probably need to get more nutrients early in the day so they can try to break their pattern of leptin resistance. So leptin is the master hormone that tells the hypothalamus how much fat you have on your frame. And you really can help reverse the leptin resistance by getting early morning light on the eyes and on your skin, as well as timing the nutrients that come into your gut. So for those people, they really should be eating within an hour of the sunrise. Now, if somebody's very healthy, maybe they don't necessarily need to do that. And, I'm not opposed to people fasting on occasion, but it really has to have a reason why they want to do that. The risk is if you do too much, quote, intermittent fasting, there may be not time through the day to get to your protein goals. It's very challenging to hit 160 grams of protein a day if you say your feeding window is only 4 hours per day.
What about periodic longer fasts? Somebody wanting specific benefits such as autophagy and periodically, say 4 times a year, doing 3-day water fasts.
Again, it depends on why they're wanting to do those things. I mean, I personally don't do those. I don't think there's a need for myself to do it. But if somebody has a real good reason why, then they just got to make sure that, they're staying well hydrated at the times. They're not going to be on some electrolytes, so they're not getting lightheaded and dizzy. Maybe they can do branched chain amino acids, but they should be focusing on doing some type of strength or resistance training those days. Because if you're going to be, without nutrients for days and you're not moving your body's in a catabolic state, your body's going to be like, hey, muscle, why don't you give us some of this protein? We need that now because we're not getting any through our GI system. So if you do too much fasting, you can basically, cut back on your, muscle reserve essentially. And then it's harder for you to kind of gain it back in the future. So I'm a big stickler. Like, you don't want to do things that work against your muscle health.
Let's talk more about hydration. And this can tie back to what you brought up earlier about the structured water. But you also just mentioned hydration with electrolytes. Let's start out talking broad, hydration as a whole, and what you consider a good practice.
It really comes down to the water that the mitochondria make. That's actually the name of the game. The water that you drink, it's much, secondary to that. So the water that you drink, ideally, should be fluoride-free either naturally because it's spring water or glacier water, or you use some type of reverse osmosis or some filter that for sure removes fluoride from that water. You want fluoride-free water. Fluoride's a dielectric blocker. It affects how well your body can store energy in the water that the mitochondria is making. And fluoride's a neurotoxin, thyrotoxin, and disrupts the oral microbiome. So you do not want to be drinking fluoridated water. That being said, how much per day? There's not an exact number. You don't have to hit exactly 80 ounces a day or a gallon a day. Just try to avoid from getting to the point where you're feeling, visibly dehydrated, dizzy, lightheaded, parched mouth. Like, you're doing more activity, you need more electrolytes and fluid at that time. Electrolytes too, because you're sweating out the sodium, the potassium, magnesium. So many commercial people make different electrolytes. I don't have any affiliation with any of them, but I use them when I'm doing a lot of physical activity. That being said, get your water clean and then focus more on how the mitochondria make their water. And that's about getting the proper light signals on your skin. That's about sleeping well.
How do you feel about structuring water before it enters the body? And this is different than the structured water that's being produced in the body, but there are different devices that can be used, vortexing. Is that something you bother with?
I have one. I've used it. Do I notice any difference? No. Is there any way I could test that it would do anything different in my body? No. Does it make somewhat sense? Possibly, but I think people are getting really into the weeds once they're down to like, I need to keep my water on a Magnetico sleep pad. It has to be copper around it. It has to be out in the sun to get more infrared light. I have to vortex it and put special crystals in it so the water's better. It's like you can do that stuff, or just focus on what can your mitochondria do, and do the simple things first. So I think it's much more important to think about getting the right light signals on your surfaces and trying to structure the water internally than worrying about the water that you're drinking. You can do it, but I don't spend a lot of time focused or worrying about it.
Another one of the big pillars in the quantum world is grounding. How do you feel about doing that outdoors on a regular basis and then bringing grounding mats into the home to be able to do that in a biohacking way?
Sure, great question. So grounding is definitely something that has a lot of study, and there's a kind of called the godfather of integrative cardiology, Dr. Stephen Sinatra. He did research many years ago that had shown that grounding outside improves the zeta potential, where the red blood cells don't stick together as much. It basically thins the blood. It helps regulate the autonomic nervous system, so it decreases stress that the body is sensing. So for the quantum people that might be listening, it's because those electrons you're absorbing while grounding are helping, in part, cause the structured water around the red blood cells and the glycocalyx to basically repel each other. So definitely a fan for people being outside, connected to the earth with their hands and feet. There's companies that make grounding shoes, that have different plugs in them if you need those because it's freezing where you're at. But ideally, you're getting outside and being grounded as much as you can. Humans are the only animals that electively decide not to ground. Every other animal is grounded all the time. They sleep grounded. They sleep in the trees. They're in the water and grounded. Humans are the only ones that decide to wear rubber-soled shoes and sleep in beds that aren't grounded. And when you're grounded, you're basically recharging your system. But I get that question a lot. Like, what about grounding mats and pads, and can I sleep on them? I said you can, but you really don't know what you're doing to yourself sometimes. If you plug something into your AC power system, you're then going to have issues where you're potentially an antenna for other non-native EMF. So essentially you put a mat, you sleep on it, you're attracting, things to you that you may not want. Now, I've had people do this and they report great sleep and that their joints don't feel bad, that everything's great for them. Great. But I've also had people do it and they're very nauseous when they use these devices when they're plugged into the AC system, or they have crazy nightmare dreams. Not worth the trade-off for those people. So I tell people if they're going to bring grounding technology inside, it ideally should still be connected to the ground outside, not be plugging into the walls. Even if it comes with a little tester that says it's grounding, that just means you're probably not going to electrocute yourself if you plug it into the wall. If you're going to use this technology, run a copper wire from the pad or mat, put it out your window or door, and put it around a copper stake and drive it into the ground. If you're doing that, probably I'd be okay with people doing it that way.
As a cardiologist, how do you think about high blood pressure? And conventionally thinking, doctors will often recommend decreasing or cutting out salt. Layer on that piece.
There are people that are salt sensitive, but in part it's because the glycocalyx buffers sodium. So if you have a terrible glycocalyx and that person is having a high salt diet, their body can't buffer it. And that's going to cause more fluid retention and raise their blood pressure. But blood pressure, I sometimes joke, it's not a disease. It's a response to something in the environment. Sometimes it's due to white coat hypertension, which is basically stress-induced hypertension. So if you have high adrenaline, the arteries are going to constrict. You're trying to get away from a threat. Is it low nitric oxide? We just talked about that at length. So if you have low nitric oxide, that often drives higher blood pressure. There's many things that can drive blood pressure, but many of them are genetic. Maybe upwards of 80-90% of reasons people have high blood pressure, there's some genetic locus that does that. And you can do the Vibrant America CardiX panel to figure out which gene that may be. But if you do the things we talked about earlier and you're still having high blood pressure and you've done all the basic things to support nitric oxide, then you really do have to consider pharmaceuticals if your blood pressure is persistently staying greater than 140/90, because elevated blood pressure is a silent killer for a reason. You don't have any symptoms. You don't have anything that you can be like, oh, my blood pressure is normal or not normal. But the organs, when they're facing these higher pressures, will basically become, over time, damaged by that high pressure, particularly the kidneys and the small blood vessels in the brain. So if you start having kidney impairment, that's the big canary in the coal mine that, there's a big problem in your vascular system. So there's a big workup. It probably takes us 2 hours to explain exactly all the things you can do to work up high blood pressure. But the first thing is you got to monitor it. If you don't check, you don't know. So I recommend everybody have a blood pressure monitor, at least have access to one, and check and see, are you still truly less than 120/80? Because that's really where, if you're persisting greater than that long term, you got to do something about it.
Whether it's high blood pressure, plaque building up in the arteries, a lot of this stuff related to heart disease is silent and acting in the body for a period of time, oftentimes before people notice. And what I'm getting at here is the person tuning in at home right now, wondering where they fall on the continuum. Obviously, going to see a cardiologist or doctor and getting the proper testing done is key. But just to get a subjective idea, what are some different symptoms somebody could look at right now to determine whether or not heart disease and some of these other conditions that fall under that umbrella are acting silently in the body?
That's the challenge, is most people do not have symptoms. By the time you got symptoms, you're almost too late to the game. You're probably going to end up getting, stents or bypass surgery, or you're very high risk of having a cardiac event. So you don't want to wait till you're having crushing chest pain when you exercise, or you're so short of breath you can't walk up one flight of stairs. Those people rarely don't, miss the opportunity to go to the ER or hospital and be like, hey, this isn't right. It's the person who has no symptoms who has sudden cardiac death at home that you're worried about. And I've seen this way too many times in my career, and so has probably the majority of cardiologists that might listen to this if they ever listen, is that you see somebody who looks very, very healthy on the outside. They don't smoke. They don't have high blood pressure. They're not diabetic. They don't necessarily have a strong family history. Their cholesterol is not, quote, high, and they still have a heart attack. I've seen triathletes who had heart attacks during the triathlon. So it's possible to be very, very fit and look like you have a very fit, body, but you can have significant atherosclerosis. It's not uncommon. The people who are sometimes the most fit, doing a lot of the high volume endurance exercise, tend to have a lot of oxidative stress and inflammation that really ages their arteries faster. So it's the test don't guess philosophy. Just because you look healthy on the outside, you really don't know until you go looking on the inside. So you can start with, simple things like, is your blood pressure normal at home? If you need to get one test, not a perfect test, but a pretty good tiebreaker for most people, is a CT coronary calcium score test. If you get that test and your score is 0, and whatever you're doing for yourself, for the most part, means you're low risk. You still could have soft plaque, you could still have other things that are an issue, but at least at the moment, you're not in that high risk category.
What about just looking at waist circumference? And that would tie back to insulin resistance, the metabolic health we were talking about initially. Is that a fair way for people to kind of get an idea?
For sure. But not everybody's, measuring their waist and making sure it's under, 35 centimeters for women or 40 for a man. So, the quick thing is take your hands, run them down your sides, run them down your front and back. And if you feel big bumps, you have some, visceral fat in your system. The visceral fat is the fat that's around your organs. That's the inflammatory type of fat.
What do you think about this earlobe crease? From time to time, I'm searching around online and I see people talking about it. Any validity?
Sure. So I'll start from the feet and work up. So, a couple things, and this is only for guys, is if they have leg hair and then all of a sudden they don't have leg hair, that can be a telltale sign that they're developing peripheral arterial disease. If they start losing leg hair, sometimes it's due to the microcirculation of the hair follicles or dying off, and then the hairs fall out. So unless the guy is like shaving their legs or something like that, if you see that, you start working that person out for vascular disease. If they have erectile dysfunction as a man, that's the canary in the coal mine that the blood vessels, the sexual organs aren't working well. You likely have vascular disease in your coronary arteries. You need to go looking. But the sign that you're mentioning is that's known as the Frank sign. It's a diagonal earlobe crease. It's thought to be because there's a collagen issue in those individuals. And if they have that earlobe crease, there's an association with increased coronary artery disease. It is not 100%, correlation that if you earlobe crease that you're, going to have it, but it's enough that if you have one, or a lot of people in your family do, and you can correlate that, hey, grandpa had that and he had a heart attack, you probably should be getting screened for it. I look for it in every patient. I do comment on it. And it's kind of like a party trick for cardiologists walking around in public that, you're at, the store and you see somebody with earlobe creases and like, hey, here's my business card. You might want to get screened.
Right. So it can be valuable, but you don't put a lot of weight in it.
Correct. There's a lot of other things I'd be more worried about.
Let's come back to diet. And hearing you go through your diet, it doesn't sound like saturated fat is a concern for you. But again, conventionally, a lot of cardiologists are having people on low-fat diets to bring that LDL down. Talk about how you think about saturated fat.
It's a variable I look at, and it's not important in everybody. Yeah. I've definitely seen the patients who've had, quote, normal cholesterol, switch up their diet to keto or, a higher fat type of a carnivore diet, and their lipoproteins then go to the range where it looks like they got familial hyperlipidemia. In those individuals, it's likely that they are, sensitive to saturated fat. Now, there are different genes that can affect that, but, one of the major ones is if they have an ApoE4 allele. If they have an ApoE4 allele, it may happen to them. Doesn't happen to all of them, but you tend to see it more. They have issues with their LDL receptors. There's other genes that can affect lipoprotein lipase, how well you break down certain fats. But I often will look at the cholesterol balance test in the Boston Heart diagnostic panel and the fatty acid balance panel on that same lab company. And it can tell me, is the person a hyperabsorber of sterols? If they're absorbing a lot of fats from their gut, okay, they may be more set up for this. And then you can look at the fatty acid balance panel and see like, oh, their saturated fat on the red blood cell is very, very high. Seems like this might be what's driving it. And those individuals, they got one of two choices. They can either alter the diet, and if they want to stay on a higher fat diet, they maybe transition to more polyunsaturated fats from seafood or more monounsaturated fats from olive oil or avocado, and then see does it have an effect on their lipoproteins. Or the person's not willing to change their diet, then depending on what's going on in the vascular system, they should consider pharmaceutical interventions to lower their lipoproteins.
Let's tether this to seed oils. Again, conventional cardiologists would often recommend these as a tool to bring down the LDL. In our world, they're looked at by a lot of people as the devil, and they cause all kinds of problems, including insulin resistance. Where do you fall in that continuum?
It's definitely a continuum, But, I tell people, eat real foods. I don't think anybody's having an argument about, people should eat highly processed foods, and that's going to be healthy for them. But the issue with some of the seed oils, it's that it's often pro-inflammatory when it's out of balance with how much omega-3 the person's eating. If they're not eating any seafood, and I prefer they eat the seafood versus supplementing it, then they may have high levels of inflammatory compounds in their blood. High-sensitivity CRP being one of them. So generally, if their ratio is 4-to-1, where they're eating no more than 4 times omega-6s to omega-3s, they're probably not going to have a lot of inflammation or oxidative stress. But it really comes down to seed oils is that it's literally the amount of deuterium that's in them that's the problem. And deuterium is heavy hydrogen. That heavy hydrogen in them basically plugs up the mitochondria's ability to make energy efficiently. That's the most simple way to think about it.
Let's expand out on deuterium. I'm interested in this. This can tie back to when we were talking about different foods in different locations. So somebody who is importing fruit from down south to, say, where you're at in the wintertime and eating that, that's going to be high deuterium, which can impact the mitochondria. So I'll have you expand on that.
I learned a lot of this information from Dr. Jack Kruse. He tells people in his older, content is that, hippos and lions don't need to be told what to eat, but humans for some reason think that they have to break the Mother Nature's rules. So if the food doesn't grow in your environment, you're not designed to eat it. So if you're in a place where the ground is frozen and you're bringing up bananas in January, that food is high in deuterium because it required a lot of UV light to grow it. Came probably from the equator. So you're putting a food into your belly that grew at the equator. The photonic, I should say, the electrons in those foodstuffs are basically programmed by the light from the equator. So your stomach is basically saying, hey, the summer is in my belly, and you go outside and your skin is freezing and your eyes are sensing the lack of UV light because you're in vitamin D winter in St. Louis in January. Your body's like, it's winter, but my belly says it's summer. Why is that disconnect happening? That would have never happened until we start shipping food this way. But those foods from the equator, high carbohydrate rich foods, are high in deuterium. Deuterium, if you don't have well-functioning mitochondria, will damage their ability to make energy. So, that's why sometimes people will temporarily have a boost in, their energy levels because when they go keto, they're not eating all that type of high deuterium foods. But there's definitely ways to have high processed keto foods that are going to still have high levels of deuterium. So it's not a guarantee that eating keto or carnivore is going to, keep that out of your diet. So that's why you really should focus on the seasonally appropriate diet and eating foods that are minimally processed, not saying eat raw foods all the time.
Say you're in a situation where you're at a party and you're eating a bunch of fruit. I don't even know if you do this, but hypothetically, and you've brought in a lot of deuterium beyond what you normally would. Anything you could do to hack that and bring it back down?
It's the fluids leaving your body, the urination, the fecal elimination, sweating, getting those things out of the system is how ultimately you get rid of deuterium.
What about drinking deuterium depleted water?
It's an advanced topic and needs to be in the context of the person who is sitting in front of you with, whatever condition. Those people tend to either have some type of active cancer or autoimmune condition that they really need to consider that. The average healthy person really should put, DDW on this, hey, something might be interesting, but not something you really need to explore.
Throughout the conversation, you've dropped a couple of different supplements, but for somebody living and eating by the principles we're talking about today, what core supplements would they want to consider?
There are literally no supplements I tell people everybody has to take. I never do. It's all in context of what the testing shows. I have people who have zero supplements and their arteries look great. There's people who, who try to optimize it through their exercise, their stress management, their sleep, but they're deficient in certain things. If they can't get them through places, then I'm okay with them supplementing at that point. But you want to minimize the supplements and not say everybody's got to take fish oil, magnesium, curcumin, or they're not going to have good arteries. That's just not true.
What about vitamin D? Somebody up north like yourself in the winter. There's mixed people, I shouldn't say people, but mixed opinions on whether or not to take it. Explain why you don't.
The simple thing is that vitamin D is a hormone. And anytime you put anything into your body that's a hormone and your body can produce it, you can downregulate how your body produces it then. But the other thing is that taking a pill doesn't mean that it does the same thing in your body as when sunlight strikes your surfaces and the UV light sulfates the cholesterol into the precursor that becomes vitamin D. Your body also produces other metabolites of vitamin D from sunlight that are not present in the pill. So the pill does not necessarily affect the immune system, doesn't affect nitric oxide pathways like the sun-produced vitamin D does.
How do you feel about cold therapy, cold immersion?
Personally, I do it. I have a cold plunge unit, but I've been doing this for a while. So again, it's one of those things where, people should not literally go jump into a cold bath until they know what they're doing and know what else is going on in their system. I've 100% seen people throw themselves into atrial fibrillation doing too much cold plunging. So if you don't know what you're doing, you could hurt yourself with this stuff. So, but cold can help with mitochondrial function. It helps electrons flow faster through the mitochondria. It helps with lowering inflammation. The joke is like, where do you keep most of your produce and your meat so it doesn't spoil? You keep in the fridge or freezer. The cold prevents things from spoiling. You're basically something that's going to spoil long term. So the cold can help with that.
You mentioned the fact you have a cold plunge. What are some of the other biohacks you use on a regular basis, whether it be in your office or at home? Light therapies, air filters, different ways to create healthy inputs for your body.
Always start with the light ones first. So if I'm inside and I don't control the light environments, I always have on, my blue blocking glasses. So yellow ones during the day, If I needed to change up like exactly when I sleep, then I would throw on the darker amber or red lenses. But my sleep is very dialed in. I don't need those. My house is naturally lit. Uh, I have many photo biomodulation panels, and the short answer is they are sun supplements. You always want to use full spectrum sun, but if you don't have access to it, or you have a local injury that you want to treat, then the red light panels may be useful in those instances. Um, cold, do it on occasion. Don't do it routinely. Have access to a sauna. Sauna is extremely important for structuring the water in your body, detoxifying. Can help with lowering blood pressure. Stimulates, heat shock proteins. It helps activate certain things that help with your immune function. So sauna, cold, red light therapy. Those are kind of the mainstays. You know, yes, I do have some HEPA filters, at least in the bedrooms, to keep the air as clean as I can. That's the basics essentially.
I want to come back around to something we were talking about early in the conversation. And we got into the disruption of the glycocalyx, endothelial dysfunction that impacts nitric oxide. But let's talk about plaque. We talked about the two different ways it can gradually increase and cause an occlusion of a vessel, or more drastically. But let's talk about specifically the more sudden, the rupture. What specifically causes that? And then what's the physiology that happens afterwards?
There are variable causes, but high shear stress, oxidative stress and inflammation that thins out the cap of the plaque, probably the most common reasons. So think a plaque in the artery is a pimple. If it has a very thick cap over it, it's not likely to rupture. If the artery lumen starts getting occluded to where it's 70% occluded, you may have stable angina. You'll have chest pain when you exert yourself and get your heart rate up, but that plaque is not likely to rupture. Unfortunately, when I said earlier, still true, half the time people have heart attacks, the arteries might look something like this. They got 30% blockage in the artery. They can't feel that. But that plaque, if it is thin capped, think of it as like a red hot pimple. The cap ruptures, the damaged modified oxidized LDL, the macrophages, the other immune components that are in that plaque, they then spill out into the bloodstream. The body then senses that event as a bleeding event. The body, someone thinks like the body's bleeding externally. And then platelets get activated. The platelets form a plug. It seals that rupture, but it also acts like a dam. It prevents the blood flow going downstream. So whatever tissue downstream is being starved of its oxygen and nutrients. So if it's in the heart, that's a heart attack. If it's in the brain, it's a stroke. If it's in your gut, it's going to be a mesenteric, infarct, and you're having belly or gut pain, or a kidney infarct. So the rupturing process is generally sudden. The person did not have symptoms before that happened.
How do you feel about the clotting aspect and the quality of the blood and things we can do to impact that and make sure it's got proper viscosity and such?
Well, we talked about those things earlier. It's grounding to improve the zeta potential. It's doing things that structure the water in your body. So sun exposure, exercise would help with that. Sauna could help with that. So it's mostly the lack of infrared light and the lack of grounding, getting electrons through that way to do it is one of the things that causes the blood to be more viscous, more like ketchup, less like red wine.
Okay. What about specific things like people talk about fish oils to keep the blood thin, other dietary changes, supplements?
I mean, it's more of a myth that fish oil is a blood thinner. I mean, it may help with some of the platelet aggregation, but it's not like aspirin, clopidogrel, or like, the anticoagulants like warfarin or, Xarelto. It's not like those things. So, I mean, people can, I think there's older studies where people were eating like 20 grams a day of omega-3 and they had no increased risk of bleeding. So I don't really consider omega-3s as a, blood thinner. But, there's people that, will talk about nattokinase, serrapeptase, lumbrokinase. If you have high fibrinogen levels, maybe it makes sense, but I don't think the average person needs to really, really be focusing on that.
Genetics have come up a few times. I want to end on this. FH, you quickly brought it up. How often are people coming to see you with this genetic component? And how different is the diet and lifestyle with that person?
So how often do people come see me? Well, I have a kind of a unique, practice. So more common to see them than probably a general cardiology practice would, because people know my expertise for looking at lipoproteins and helping with vascular diseases. So I just, before this interview, saw somebody who traveled from halfway across the country to come to see me who has confirmed familial hyperlipidemia, has an issue with their LDL receptor. So the LDL receptor sits on the outside of the liver and plucks the cholesterol particles out of the circulation. This person doesn't make very many of those, so their LDL particles were extremely high. And because they already have somewhat advanced vascular disease for age, they're on very aggressive pharmaceuticals and are doing very well at this point. But the differentiator is that this person had high lipids since they're first started checking in their 20s. So the person who's following more of a keto type diet and is now, quote, a lean mass hyperresponder, they have to have had some type of panel in the past that was, quote, normal. And then you see a significant elevation in their LDLs, typically above 190 milligrams per deciliter. It mimics familial hyperlipidemia, and they may still get atherosclerosis with that. Just because they're metabolically healthy doesn't mean that their arteries are immune from developing plaque from that number. So that's why you have to test and not guess on it. But if you do the right type of genetic testing, you can rule out that it's not due to familial hyperlipidemia. But oftentimes it's due to polygenic reasons. So the GB Health Insight Panel can tell you, say perfectly ate, you exercise every day. If you have a, polygenic risk score for hypercholesterolemia of 98 out of 100, you're going to have high levels no matter what you do. Then it's your choice to decide if you want to take, therapies to adjust your lipoproteins at that point. But if you have plaque in your arteries, you probably should be considering that.
Dr. Twyman, thank you for your time. Really enjoyed this.
You're very welcome. Thank you for the opportunity today.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not being